Okay, let's unpack this. You know that feeling.
Mm-hmm.
One moment you're feeling fine, the next you're maybe a little warm, achy, uncomfortable, and then you take your temperature and boom, you've got a fever.
Right.
Or perhaps on top of feeling unwell, you notice something appearing on your skin, a rash.
Yes, those two together.
These aren't just minor inconveniences, they're two of the most fundamental, common ways our bodies signal that something significant is happening internally. But what exactly is going on under the surface when these appear?
Well, these responses are far more than simple symptoms. They are cardinal manifestations of disease, really outcomes of intricate biological processes designed to respond to threats and changes within the body.
Exactly. And today we are embarking on a truly deep dive. We're taking a stack of material that focuses intensely on these two powerful signals, fever on its own,
And the combination.
and the complex diagnostic puzzle that emerges when fever is combined with a rash. Our mission is to pull out all the essential knowledge, every concept, every detail presented in these sources.
Really get into the weeds.
We want to go deep enough that you can grasp and truly master this information, understanding it like the experts in this field do.
Absolutely.
It's about understanding not just what fever is, but why it happens, how it's precisely regulated, and what its presence signifies.
And then how the rash adds another layer.
And then how combining that understanding with the specific characteristics of a rash creates a unique clinical picture that demands careful interpretation. We're going to cover everything these sources offer to give you that comprehensive, expert-level picture.
That's right. We're moving beyond surface recognition to explore the underlying science and clinical significance in quite a bit of detail.
All right, let's start by going deep into fever itself, drawing from our material in Chapter 18. At the absolute core of how our body controls its temperature is the hypothalamus.
Right, the command center.
Think of it as our body's incredibly sophisticated central thermostat.
That's precisely it. The hypothalamus, specifically neurons located in both the preoptic anterior and posterior areas, serves as the command center for thermoregulation.
Okay.
It's constantly receiving crucial information from two main sources. You've got sensory input from peripheral nerves, which tells it about the temperature of your skin and extremities,
Out on the surface.
and direct measurement of the temperature of the blood flowing right through that area of the brain, the core temperature.
So it's getting real-time feedback from both the body's surface and its core circulation.
Precisely. The thermoregulatory center within the hypothalamus integrates all these signals to maintain our core body temperature within a surprisingly narrow normal range.
And what is that range, typically?
The standard range often cited is 36.5 to 37.5 degrees C, which is 97.7 to 99.5 degrees for occasion.
And the body's always working to stay within those bounds, balancing heat production and loss.
Yes. In a neutral environment, our normal metabolic processes, especially in muscles and the liver, actually generate more heat than we strictly need.
Oh, interesting.
So the hypothalamus directs the body to balance this heat production with heat dissipation, which occurs primarily through heat loss from the skin and, to a lesser extent, the lungs.
Okay, so that's the system working as designed. But what do we really mean by normal temperature? The sources point out it's not quite the simple single number maybe we once thought.
It's certainly more nuanced than the old 98.6 degree ARFA standard. A significant study referenced in the material looking at oral temperatures in over 35,000 healthy individuals during routine visits
Wow, that's a lot of people.
found the mean oral temperature was actually 36.6 degrees C, with a 95% confidence interval stretching from 35.7 to 37.3 degrees C.
So quite a spread there.
Based on this real-world data, fever is typically defined as an oral temperature greater than 37.7 degrees C, which truly represents the 99th percentile for healthy people.
Okay, that feels like a more rigorous definition. 37.7 degrees C oral.
Yes.
And the sources were quite detailed about the surprising amount of variability in baseline temperature across different people and conditions.
Absolutely. Baseline temperature isn't static. It can be higher and higher ambient temperatures. There are distinct diurnal and seasonal variations, generally lowest around 8 a.m. and during the summer,
Okay.
and highest around 4 p.m. and in the winter.
Afternoon peak.
Right. Age influences it, with baseline temperature decreasing by about 0.02 degrees C for every decade of life.
Gets lower as we age.
And demographic factors show small but measurable differences. That large study noted African American women had temperatures on average 0.052 degrees C higher than white men. And existing health conditions matter? Cancer patients had temperatures about 0.02 degrees C higher, while those with hypothyroidism or about 0.01 degrees C lower.
Small differences, but consistent. Here's where it gets really interesting. The sources mention an intriguing link they found between even subtle shifts in baseline temperature and future mortality.
This is a fascinating finding from that study. After adjusting for numerous potential confounders like age, sex, race, other vital signs, and comorbidities,
Controlling for everything else.
an increase in baseline temperature of just 0.15 degrees CE, roughly one standard deviation in that population, was associated with a 0.52% absolute increase in one-year mortality.
Wow, that small a difference, 0.15 degrees, correlated with a statistically significant outcome.
Indeed. It really adds weight to the idea that baseline temperature is a key vital sign, not just some static number.
And speaking of numbers, the source of the temperature measurement matters too, doesn't it? Where you take it.
It absolutely does for accurate interpretation. Rectal temperatures are consistently higher than oral readings, typically by about 0.4 degrees C or 0.7 degrees Fahrenheit.
Why is that?
This difference is often attributed to cooling effects in the mouth, especially if someone is breathing heavily or, has respiratory issues.
Makes sense.
Lower esophageal temperature, measured deep inside the body, is considered to be the most accurate reflection of true core body temperature.
But not very practical for everyday use. What about the tympanic membrane thermometers, the ear ones so many people use?
They measure radiant heat from the eardrum and ear canal. They could be presented as an unadjusted reading or one adjusted based on comparison studies.
Okay.
The sources note they can be more variable than oral or rectal measurements. Specifically, unadjusted tympanic readings are lower than the adjusted ones, or about 0.8 degrees C or 1.6 degrees air fat lower than corresponding rectal temperatures. So you need to know which mode you're using and what you're comparing it to.
Consistency is key. And for women, there's a variation tied to their menstrual cycle.
Yes, in women who menstruate, the morning body temperature is typically lower in the 2 weeks leading up to ovulation.
Before ovulation.
Right. With ovulation, it usually rises by about 0.6 degrees C or 1 degrees F and remains elevated throughout the luteal phase until menstruation begins.
Another factor to consider. So normal temperature is quite a spectrum, influenced by many factors and measurement sites. Now, the material makes an absolutely critical distinction that we need to nail down for mastery. The difference between fever and hyperthermia.
Yes, fundamentals.
They are not the same physiological process.
This is absolutely fundamental. Fever is precisely defined as an elevation of body temperature above the normal daily variation that occurs in conjunction with an increase in the hypothalamic thermoregulatory set point.
The set point changes.
Exactly. Imagine your home thermostat. Someone has deliberately turned the desired temperature up. The source gives the example of the set point being reset from, say, 37 degrees C to 39 degrees C.
Okay, and once that set point is raised, the body initiates actions to reach that new, higher target temperature.
Exactly. Neurons in the vasomotor center activate, causing vasoconstriction, particularly noticeable in the hands and feet where you might feel cold.
Right, the cold hands and feet.
This shunts blood away from the skin surface, significantly decreasing heat loss. Shivering, which generates heat through muscle activity, may begin, though it's not always required.
Okay.
There's also increased non-shivering heat production, largely from the liver. And we instinctively make behavioral adjustments, like bundling up or seeking warmth.
Putting on blankets.
Right. These heat conservation and production mechanisms continue until the blood temperature bathing the hypothalamus reaches the new elevated set point.
Okay, so the body is actively defending this higher temperature. It wants to be there.
Precisely.
And when the fever breaks or you take medicine, what happens then?
Well, when the hypothalamic set point is lowered back towards normal, either because the underlying fever-causing agents diminish or because antipyretic medications are introduced, the body then initiates mechanisms to lose heat.
The opposite happens.
Exactly. Vasodilation occurs, leading to flushing and a feeling of warmth in the skin. Sweating begins, which is a highly effective way to dissipate heat through evaporation.
Okay.
Behavioral change is reversed. You might throw off blankets. This process continues until the blood temperature matches the new lower set point.
So fever is a tightly regulated process with a raised thermostat setting. What about hyperpyrexia? That sounds serious. It's an exceptionally high fever, over 41.5 degrees C or 106.7 degrees Fahrenheit.
Hyperpyrexia is fever at an extreme level, yes. While it can happen in severe infections, it's most commonly seen in patients with central nervous system hemorrhages or trauma,
Brain issues.
where the hypothalamic control might be directly affected in a specific way that elevates the set point excessively. The sources mention speculation from the pre-antibiotic era that fevers rarely exceeded this level, possibly due to a natural thermal sealing mediated by the body's own neuropeptides acting as central antipyretics.
Like a built-in safety mechanism.
Potentially, yes.
And hypothalamic fever itself, is that a distinct thing?
In rare instances, localized damage to the hypothalamus from trauma, hemorrhage, tumor, or a malfunction in the regulatory pathways can directly cause an elevated set point. This is sometimes loosely referred to as hypothalamic fever.
But it's rare.
Very rare. And it's crucial to note that most damage to the hypothalamus actually leads to subnormal body temperatures, not elevated ones.
Okay, that's important. So that's fever. A regulated increase driven by a set point change. How does hyperthermia fundamentally differ?
Hyperthermia is an uncontrolled rise in body temperature that simply overwhelms the body's ability to lose heat.
Overwhelms the system.
Right. The critical difference is that in hyperthermia, the hypothalamic thermoregulatory set point remains unchanged. The body is still trying to maintain normal temperature, but it cannot cope with the excessive heat load or impaired heat dissipation.
So the thermostat is still set to 37 degrees C, but the actual temperature is just climbing uncontrollably.
Exactly. Unlike fever, hyperthermia is not triggered by pyrogenic molecules.
No pyrogens involved.
Correct. It results from either excessive exposure to external heat, like in extreme environmental conditions or saunas, or from excessive internal heat production that outpaces heat loss, like strenuous exercise in the heat, certain drug reactions, or metabolic conditions.
And the sources stress that distinguishing between fever and hyperthermia is critical, especially in an emergency.
Absolutely. Hyperthermia can be rapidly fatal, and critically, it does not respond to antipyretic medications like aspirin or acetaminophen.
Because there's no elevated set point to lower.
Precisely. While differentiating can be challenging, especially in cases of rapid onset, very high temperatures like those sometimes seen in severe sepsis, hyperthermia is often diagnosed based on the context, a history of heat exposure, intense exertion, or exposure to drugs known to affect thermoregulation.
And a key physical difference. You mentioned vasoconstriction in fever onset.
Yes. In hyperthermia syndromes, particularly classic heat stroke or drug-induced hyperthermia where sweating is impaired, the skin is typically hot and dry.
Hot and dry.
In contrast, during the onset phase of fever, when the set point is rising and the body is conserving heat, the skin often feels cold and is vasoconstricted. Also, adequate doses of standard antipyretics will reduce temperature in fever, even hyperpyrexia, but have no effect in hyperthermia.
That is a vital distinction for treatment.
Understanding this distinction is absolutely vital for correct treatment.
Okay, that distinction between the regulated set point shift fever and the uncontrolled temperature rise, hyperthermia, is absolutely fundamental. So what are these pyrogens that trigger the regulated set point change in fever?
Pyrogen literally translates to firemaker. These are substances that induce fever. We categorize them into two main types based on their origin.
Okay, first, exogenous pyrogens, from outside.
Exactly. These come from outside the patient's body. The most common are microbial products, toxins, or the microorganisms themselves.
Like bacteria.
Right. The quintessential example is lipopolysaccharide, or LPS, also known as endotoxin, found in the cell walls of gram-negative bacteria.
LPS, okay.
LPS is incredibly potent in humans. An intravenous injection of just 2 to 3 nanograms per kilogram is sufficient to cause fever and other systemic symptoms.
Wow, tiny amounts.
Very potent. Other examples from gram-positive bacteria include toxins produced by Staphylococcus aureus and group A and B streptococci, often called superantigens.
Superantigens?
These can induce fever at slightly higher doses, typically 1 to 10 micrograms per kilogram.
Okay, those are the outside triggers. And then there are endogenous pyrogens, which we now primarily refer to as pyrogenic cytokines. Inside triggers.
Right. These are small protein molecules produced by the patient's own cells, primarily immune and inflammatory cells. They act as signaling molecules that regulate various processes, including immune responses, inflammation, and blood cell production.
Like making more white blood cells.
Exactly, like causing the increased white blood cell count often seen with infection. A specific subset of these cytokines is pyrogenic. They directly cause fever.
Which ones are the key players?
The key examples include interleukin-1, IL-1, interleukin-6, IL-6, tumor necrosis factor, TNF, and interferon alpha. Each is encoded by a separate gene and can induce fever in both animals and humans when administered.
And different ones need different amounts to cause fever.
Yes. Relatively low doses of IL-1 and TNF in the range of 10 to 100 nanograms per kilogram can induce fever in humans.
Pretty potent, too.
IL-6 typically requires a higher dose, around 1 to 10 micrograms per kilogram, to produce the same effect.
Are these pyrogenic cytokines only produced in response to bacterial products like LPS?
Not at all. While microbial products like LPS are potent inducers, fever can also occur in the absence of a microbial infection.
Okay.
Various non-infectious inflammatory conditions can trigger the release of these same pyrogenic cytokines. Examples include processes like acute pericarditis, significant trauma, stroke, myocardial infarction, certain crystal-induced inflammations like gout.
Gout can cause fever.
Yes, the inflammation can trigger cytokine release.
Yep.
Even routine vaccinations can do it. These inflammatory triggers induce cells to produce IL-1, TNF, and/or IL-6, which then act on the hypothalamus.
Okay, so the cytokines are the link between the trigger, infection or inflammation, and the brain. But how exactly do these circulating cytokines signal the brain to raise the hypothalamic set point? It's not like they just float right in, is it?
That's a great question, and it gets into the fascinating molecular mechanism. The central player in elevating the set point appears to be prostaglandin E2, or PGE2. During fever, PGE2 levels are significantly increased in the hypothalamic tissue and the fluid within the third cerebral ventricle, particularly concentrated around areas known as the circumventricular vascular organs.
Circumventricular organs. What are those?
These are specialized areas within the brain, like the organum vasculosum of the lamina terminalis, that have capillary networks where the blood-brain barrier is less restrictive, sort of leakier.
Ah, so things can get through there more easily.
Exactly. It allows circulating molecules better access to signal the brain in those specific locations.
But the sources mention that circulating cytokines themselves don't easily cross the standard blood-brain barrier elsewhere.
That's correct. While there's still some debate, most studies haven't shown significant direct passage of large amounts of circulating cytokines into the main brain tissue. The leading model is that exogenous pyrogens and circulating pyrogenic cytokines interact with the endothelial cells, the cells lining the blood vessels, specifically in these more permeable circumventricular organs.
Okay, so they talk to the vessel walls in these special leaky spots.
Right. This interaction at the vessel wall is the critical initial step.
Then what happens?
This interaction prompts these local myeloid cells and endothelial cells within or near the circumventricular organs to produce pyrogenic cytokines themselves,
Ah, local production in the brain.
which are then released into the surrounding brain tissue. Crucially, these cells also produce PGE2.
Okay.
Now, while circulating cytokines also induce PGE2 synthesis in peripheral tissues, contributing to symptoms like muscle aches and joint pain.
The body aches.
Right. And some peripheral PGE2 might reach the brain. But it's the elevated levels of PGE2 produced locally within the brain, particularly near the hypothalamus, that are believed to initiate the elevation of the hypothalamic set point.
So it's the brain's own PGE2 production that matters most for the set point change.
That's the prevailing theory, yes.
And how does PGE2 do that? What's the mechanism? How does it flip the switch?
PGE2 exerts its effects by binding to specific receptors on target cells. Of its 4 known receptor types, the EP3 receptor is absolutely essential for the fever response.
EP3.
Got it. Yep. Studies where the gene for the EP3 receptor is deleted in mice show that these animals do not develop fever in response to challenges with IL-1 or endotoxin, so it's critical.
Wow. Where are these EP3 receptors found?
They're predominantly found on glial cells, support cells for neurons in the hypothalamus.
So PGE2 from nearby stimulates these glial cells via the EP3 receptor.
Yes. When PGE2 binds to the EP3 receptors on these glial cells, it triggers a rapid increase in the synthesis and release of cyclic adenosine 5-monophosphate, or CANMP, within these cells.
CANMP, heard of that?
CANMP then acts as a key signaling molecule or neurotransmitter. This elevated TMP level is thought to directly or indirectly activate neuronal endings from the thermoregulatory center that are located in that area, ultimately causing the change in the hypothalamic set point to a higher temperature.
Amazing cascade.
The sources also note that toll-like receptors and IL-1 receptors on the hypothalamic endothelium itself share signaling pathways and can directly contribute to local PGE2 production and fever, potentially providing an alternative road that doesn't require inducing peripheral PGE2 first.
So maybe a couple of ways to get there. That is an incredibly detailed pathway, starting with an outside trigger, leading to cytokine production, signaling at specific brain capillaries, producing PGE2, acting on a specific receptor on glial cells, and finally changing neuronal activity via CMP to reset the body's thermostat higher.
Ooh, it's intricate.
What if the infection or trigger is already inside the brain, like meningitis or encephalitis?
Ah, that's a distinct scenario. If cytokines are produced directly within the central nervous system, for example, if a viral infection in the brain induces microglia, or neurons themselves, to produce IL-1, TNF, or IL-6.
The brain cells make the cytokines.
These locally produced cytokines can act on the hypothalamic set point regulation centers by bypassing the need to interact with the circumventricular organs entirely. They're already inside.
And you would need a much smaller amount of cytokine if it's produced right there. Makes sense.
Exactly. Experimental studies in animals have shown that a dramatically lower concentration of a cytokine is needed to cause fever when it's injected directly into the brain ventricles compared to when it's injected systemically into the bloodstream.
Okay.
This direct CNS cytokine production is likely a key factor in the very high fevers, or hyperpyrexia, sometimes seen in cases of CNS hemorrhage, severe head trauma, or infections directly affecting the brain.
Okay, that gives us a truly deep understanding of the mechanisms driving fever. Now let's transition to the clinical side. When a patient presents with fever, how do you approach evaluating them according to the sources? What are the key steps?
The sources emphasize the absolute importance of a thorough history. You need to gather detailed information, the exact timeline of the fever, and any other symptoms.
When did it start? How high, etc.?
Right. Any potential exposures to sick people, specific disease vectors, recent travel history, immunization status, exposures to pets or other animals, history of arthropod bites, recent dietary exposures like unpasteurized dairy, any existing cardiac abnormalities or prosthetic material.
Like artificial joints or heart valves.
Exactly, which can be sites of infection, recent close contact with ill individuals, and sexual exposures, all potentially relevant.
A lot to cover. And maintaining consistency in temperature measurement is crucial, as we discussed earlier.
Absolutely vital for monitoring the course of the illness and assessing treatment effectiveness. Using the same site, oral, tympanic, or rectal, consistently allows for meaningful comparison over time.
Right.
It's also important to be aware that certain patient populations may have a significantly blunted febrile response, even when they have a serious active infection or inflammatory process.
They might not get much of a fever even if they're really sick. Who falls into that category?
Newborns, elderly patients, individuals with chronic hepatic or renal failure. And crucially, patients who are receiving immunosuppressive therapies, particularly glucocorticoids or long-term anti-cytokine treatments.
People on biologics for autoimmune disease, for example.
Precisely. They might have a severe infection or inflammatory condition without mounting a significant fever. In extreme cases, like overwhelming septic shock, patients can even develop hypothermia instead of fever.
Wow, the opposite. What about laboratory tests? Are there specific ones that are consistently helpful in evaluating fever?
A complete blood count with a careful manual differential count is standard. Looking for specific changes in white blood cells like increased band forms, immature neutrophils, toxic granulations, and dull bodies can strongly suggest a bacterial infection.
Clues for bacterial cause.
Yes, neutropenia, a low neutrophil count, can sometimes be seen with viral infections.
What about trying to measure the pyrogenic cytokines we talked about, like IL-6 or TNF? Would seeing high levels confirm they are the cause?
Well, what's fascinating here is, while cytokines drive fever, measuring circulating levels of IL-1 or TNF clinically is often not helpful for diagnosis.
Really? Why not?
Their levels in the bloodstream during fever can be quite low, or their peak may have occurred hours before the fever itself or before the blood was drawn, making detection difficult and unreliable for pinpointing the cause at that moment.
So timing is tricky, and levels might not be that high in the blood anyway. Okay, so direct cytokine measurement isn't usually the go-to test. What is more useful for detecting occult inflammation, maybe when the fever is low grade?
For detecting underlying inflammatory disease, especially when dealing with low-grade or intermittent fevers, C-reactive protein, CRP, and erythrocyte sedimentation rate, ESR, are valuable and widely used markers.
CRP and ESR, the inflammation markers.
Right. These reflect general inflammatory activity. While measuring circulating IL-6, which is a major inducer of CRP synthesis, can also be useful, CRP levels tend to remain elevated more stably over time compared to IL-6.
Yeah, more stable.
Making CRP a more practical clinical marker in many cases.
Okay. That brings us to patients on anti-cytokine therapies, like for autoimmune diseases. The sources highlight specific considerations for them when they develop fever. You mentioned they might have a blunted response.
Yes, and patients receiving long-term regimens that block cytokines, like TNF, example, for rheumatoid arthritis, Crohn's, IL-1, IL-6, IL-12 or IL-17, are at increased risk of certain infections because their host defenses are deliberately blunted.
Makes sense. You're blocking part of the immune system.
Exactly. For example, anti-TNF therapy increases the risk of latent tuberculosis reactivation, and blocking IL-17 increases the risk of systemic candidiasis.
And you mentioned these therapies can also blunt the fever response itself.
This is the significant clinical challenge.
Right.
While fever is often still present if they get an infection, the extent to which their ability to mount a fever is blunted is variable and often unknown.
You don't know how much it's suppressed.
Right. Therefore, even a seemingly low-grade fever in a patient on anti-cytokine therapy is a major concern and requires a prompt and very rigorous diagnostic evaluation to rule out serious infection.
Got to take it seriously.
Absolutely. Similarly, chronic use of glucocorticoids and even NSAIDs can blunt the febrile response.
Okay, so fever is a response, a sign. Is it always necessary or even beneficial to treat it? What's the thinking on the decision to treat fever?
The sources emphasize that fever itself is a physiological response, not the underlying illness. In most self-limited infections, like common viral illnesses, there's no strong evidence that using antipyretics delays the resolution of the infection or significantly harms the overall immune response.
So treating the fever in a cold probably doesn't hurt your recovery.
Generally not. No, they are not generally contraindicated in these settings for comfort.
But are there situations where not treating the fever might actually be helpful diagnostically?
Yes, there are scenarios where withholding antipyretics can provide useful information. If you are treating a suspected bacterial infection clinically, but don't have definitive positive cultures yet.
Right, waiting for results.
Observing whether the fever resolves after initiating antibiotic therapy can help assess if the antibiotic is effective. Routine antipyretic use could potentially mask an inadequately treated infection.
Makes sense. Let the fever tell the story.
Sometimes, yes. Withholding treatment can also sometimes aid in recognizing specific, unusual febrile diseases that have characteristic temperature patterns.
Ah, like specific fever patterns. The sources mention those. Can the pattern itself be a diagnostic clue?
Yes, absolutely. For example, Plasmodium vivax malaria classically causes a fever spike approximately every third day, tertian fever,
Every third day.
while P. malaria causes fever every fourth day, Corton fever. Borrelia infections, like relapsing fever, are characterized by periods of high fever lasting several days, alternating with the febrile periods.
Fever comes and goes.
Exactly.
Hmm.
The Pell-Epstein pattern, described as periods of fever lasting 3 to 10 days, alternating with the febrile periods of similar duration, can be a clue for Hodgkin's disease and some other lymphomas.
Interesting pattern.
And cyclic neutropenia, a hematologic disorder, is associated with recurrent fevers occurring roughly every 21 days, coinciding with a cyclical drop in neutrophil count.
Tied to the blood counts. And there are genetic conditions presenting with periodic fevers. Autoinflammatory diseases.
Yes, these are known as periodic fever syndromes, including conditions like familial Mediterranean fever, FMF, and TNF receptor-associated periodic syndrome, TRAPS.
FMF and TRAPS.
These are distinct from infectious fevers in that they are genetic autoinflammatory disorders. They differ from each other in their typical periodicity, the duration and specific features of the fever attacks, the underlying genetic mutations, and the most effective therapies.
So recognizing those patterns is key.
It can guide genetic testing and treatment decisions, definitely.
The sources also mention anti-cytokine therapy, again in the context of treating fever, but for a different group of conditions than infections in immunosuppressed patients. You mentioned autoinflammatory diseases.
Right. While fever is very common in many autoimmune diseases, recurrent, seemingly unprovoked fevers are a core feature of these autoinflammatory diseases.
Okay.
These are disorders of the innate immune system involving conditions like the periodic fever syndromes we just mentioned, disorders related to inflammasome activation, which processes molecules like IL-1, and other innate immune dysregulatory states.
Inflammasomes.
Right. Conditions such as adult and juvenile Still's disease, FMF, hyper-IgD syndrome, and even more common conditions like recurrent idiopathic pericarditis and gout are often characterized by episodes of recurrent fever, elevated neutrophil counts, and inflammation of serosal surfaces like the lining of the heart or lungs, and are frequently mediated by the cytokine IL-1.
So IL-1 beta is a key driver there.
Often, yes.
And IL-1 blockers are highly effective here.
Dramatically so. Medications that block IL-1 activity, like anakinra or canakinumab, can significantly reduce or eliminate the fevers and other symptoms in many of these autoinflammatory conditions. Interestingly, even though the primary drive for fever in these conditions is IL-1, The fevers also typically respond well to standard antipyretic medications like NSAIDs or acetaminophen.
Okay, let's go back to those standard medications. How exactly do they work? We know they lower the set point by reducing PGE2, but what's the mechanism behind how antipyretics like acetaminophen or ibuprofen lower PGE2 levels?
Their core mechanism is by inhibiting the enzyme cyclooxygenase, or COX.
COX enzymes.
Right. COX is essential for the synthesis of PGE2 from arachidonic acid. The release of arachidonic acid from the cell membrane by another enzyme, phospholipid-2, is the rate-limiting step in this pathway.
Okay.
So drugs that inhibit COX effectively block the production of PGE2, thus reducing the levels in the thermoregulatory center and allowing the set point to return towards normal.
And their effectiveness is tied to inhibiting COX in the brain, specifically.
Yes, the antipyretic potency of various drugs correlates quite well with their ability to inhibit cyclooxygenase activity, specifically in the brain tissue.
What about acetaminophen? It's not a strong anti-inflammatory elsewhere, right?
That's right. Acetaminophen is particularly interesting because it's a relatively poor inhibitor of COX in peripheral tissues and consequently lacks significant anti-inflammatory activity at typical doses.
But it works well for fever.
It does. In the brain, it is oxidized via the P450 enzyme system, and this oxidized form is effective at inhibiting COX. There's also been investigation into a possible COX3 enzyme variant in the brain, which acetaminophen might inhibit, but which isn't present peripherally. This could contribute to its central antipyretic effect.
Interesting mechanism. The sources note that oral aspirin and acetaminophen seem equally effective at reducing fever in humans. What about NSAIDs like ibuprofen?
Non-steroidal anti-inflammatory drugs,
Yeah.
NSAIDs like ibuprofen and selective COX2 inhibitors, also exert their antipyretic effect primarily by inhibiting cyclooxygenase, thus reducing PGE2 production. Same basic mechanism.
And the point about PGE2 having no role in normal temperature regulation, that seems important.
Yes, what's fascinating here is, despite its critical role in causing fever, PGE2 appears to have no significant role in regulating normal core body temperature under non-febrile conditions.
It's just for the fever pathway.
It seems to be a molecule specifically employed by the body's response systems to raise the set point during illness rather than maintaining it normally.
That's a key distinction. What about glucocorticoids, steroids? They're powerful anti-inflammatories, and the sources mention them as antipyretics too. How do they work?
Glucocorticoids are highly effective antipyretics, and they act through two main mechanisms. First, like COX inhibitors, they reduce PGE2 synthesis, but they do it further upstream in the pathway by inhibiting phospholipase A2.
Inhibiting the release of arachidonic acid.
Exactly, thus reducing the availability of arachidonic acid needed to make PGE2. Second, and uniquely, they block the transcription of mRNA for the pyrogenic cytokines themselves, IL-1, TNF, IL-6, preventing their production in the first place.
So they stop the cytokines from even being made.
Correct. They may also reduce the ability of IL-1 to induce the production of IL-6, so a broader effect.
Okay, we've covered the mechanisms. So when you decide to treat fever, what are the goals and recommended approaches?
The primary objectives of treating fever are to reduce the elevated hypothalamic set point and facilitate heat loss, thereby lowering body temperature.
Bring the temperature down.
Right. This treatment also typically helps alleviate the associated systemic symptoms like headache, muscle aches, myalgias, and joint pain, arthralgias. Makes you feel better.
Which specific agents are generally preferred?
Acetaminophen is often preferred over aspirin and NSAIDs, particularly for routine use, due to its better safety profile regarding gastrointestinal side effects and effects on platelet function.
Easier on the stomach, less bleeding risk.
Generally, yes. In children, acetaminophen or oral ibuprofen must be used because aspirin is associated with an increased risk of Ray's syndrome in children with viral infection.
Right, never aspirin for kids with fevers.
Which is a serious and potentially fatal condition affecting the brain and liver. If oral medication isn't feasible, parenteral NSAID preparations or rectal suppositories of acetaminophen can be used.
And in certain patients, aggressive treatment is particularly advised.
Yes. Fever significantly increases the body's metabolic rate and oxygen consumption, roughly a 13% increase for every degree Celsius. The core temperature rises above 37 degrees C.
That's a big jump in metabolic demand.
It is. This increased demand can severely stress organs with limited reserve, significantly aggravating conditions in patients with pre-existing cardiac, pulmonary, or central nervous system issues.
People with heart or lung problems.
Exactly. Aggressive fever control is also highly recommended for children with a history of febrile seizures, seizures triggered by fever, or even non-febrile seizures.
Treat the fever to prevent seizures.
Although the sources note that the precise temperature threshold triggering a febrile seizure and the correlation with the absolute temperature level aren't fully understood, still, it's recommended.
And for hyperpyrexia, those extremely high fevers over 41.5 C.
For hyperpyrexia, while antipyretics are crucial to lower the set point, physical cooling methods like cooling blankets should also be employed to facilitate heat loss.
Cooling blankets plus meds.
Yes, these methods should always be used in conjunction with oral or parenteral antipyretics, not as a standalone treatment for fever itself because you need to lower the set point too.
Got it.
Reducing core temperature is especially important in hyperpyrexic patients with CNS disease or trauma to mitigate the detrimental effects of very high temperatures on brain function.
So that was a very deep dive into fever itself, its complex regulation, triggers, mechanisms, evaluation, and treatment. A lot there.
Absolutely.
Huh.
We've unpacked the engine room, so to speak.
Now, let's shift our focus, drawing from Chapter 19 of our material, to explore the unique challenges and diagnostic power that emerges when you combine fever with a rash. This adds another layer of complexity to the clinical picture.
It introduces a significant diagnostic puzzle, one that is both common in practice and often quite challenging to solve quickly.
Fever and rash, very common presentation.
Very common. However, when a rash accompanies fever, its specific appearance, how it develops, and where it's located, combined with the overall clinical presentation, can provide critical clues.
The rash itself tells a story.
It can be incredibly helpful, potentially leading to a rapid diagnosis and the initiation of life-saving therapy or essential infection control measures.
So, just like with isolated fever, a thorough history and physical examination are absolutely critical here. What are the key questions and examination points when a rash is present alongside fever?
Many of the essential history points are similar to what we discussed for isolated fever, focusing on systemic factors. The patient's immune status, all medications taken within the past month, especially new ones.
Meds are key for rashes.
Very key. Detailed travel history, immunization status or lack thereof, specific exposures to pets, other animals, arthropod bites like ticks or mosquitoes, recent dietary exposures, for example, consumption of raw foods, unpasteurized products.
Foodborne illness.
Could be. Any existing cardiac abnormalities or prosthetic materials, recent close contact with ill individuals, and sexual exposures.
The usual suspects.
Right. Crucially, when a rash is present, you also need a detailed history of the rash itself. Specifically, where did it first appear, in what direction, and how quickly has it spread, and have its characteristics changed over time?
The story of the rash's evolution.
Exactly.
And the physical examination then becomes intensely focused on the rash itself. To accurately describe what we're seeing, we need a precise vocabulary. The sources provide a great breakdown of the different types of skin lesions.
Yes, mastering the language of dermatology is like getting a secret decoder ring for these presentations. Learning these terms allows you to precisely describe what you see, which is fundamental for communicating findings and narrowing possibilities.
Okay, let's define them. What's a macule?
Macules. These are simply flat areas of changed color in the skin. If they're red and blanch, disappear when you press on them. They're described as blanchable erythema, just flat color change.
Flat color change. Papule.
Papules. These are small, raised, solid bursts, typically less than 5 millimeters in diameter.
Yeah.
Small bumps.
Okay. Plaque.
Plaques. These are larger than papules raised, solid lesions greater than 5 millimeters in diameter, but they have a relatively flat plateau-like surface. Bigger, flat-topped bumps.
Nodule.
Nodules. These are also raised, solid lesions greater than 5 millimeters, but they are generally deeper and have a more rounded shape compared to plaques. Deeper, rounder bumps.
Got it. Wheels. Like hives.
Wheels or to
That's
carry
all.
eyes, exactly.
Right.
These are characteristically pale pink papules or plaques, can often have a ring shape as they enlarge. A defining feature of typical wheals is that they are transient. Any single lesion usually lasts less than 24 hours before fading and potentially reappearing elsewhere.
They come and go quickly. Vesicle.
Vesicles. These are small, circumscribed, elevated lesions containing clear or cloudy fluid, less than 5 millimeters in diameter. Small blisters.
Bullae.
Bullae. These are larger, fluid-filled lesions, essentially large vesicles, greater than 5 millimeters in diameter, big blisters.
Okay. Pustule.
Pustules. These are raised lesions that contain visible, purulent exudate, or pus. Vesicular rashes, for example, can sometimes evolve into pustular rashes, pus-filled bumps.
Purpura, the non-blanching ones.
Purpura non-palpable. These are flat lesions caused by bleeding into the skin. They do not blanch when pressed. If they are small, less than 3 millimeters, they are called petechiae.
Petechiae, small dogs.
Right. If they are larger, greater than 3 millimeters, they're called ecchymoses, like bruises, but flat.
Ecchymoses. Okay. What about palpable purpura?
Palpable purpura. Unlike non-palpable purpura, these lesions are raised. You can feel them. Their presence is highly suggestive of inflammation of the blood vessel wall, vasculitis, with associated hemorrhage into the skin.
Raised and purplish suggests vasculitis. Important clue.
Very important.
Ulcer.
Ulcer. This is a defect in the skin surface that extends down at least into the upper layer of the dermis, a break in the skin.
And finally, a char, sometimes called tache noire.
A char, tache noire, yes. This is a necrotic area of skin often covered with black, crusty scab, like a central black scab.
Okay, that's a comprehensive list of lesion types. So beyond the individual lesion type, are there other features of the rash to note?
Absolutely. You also pay close attention to the rash's configuration, for instance. Are the lesions arranged in rings, annular, or do they resemble target lesions?
Shape and pattern.
Right. You note the arrangement of multiple lesions, for example, clustered, linear, and importantly, their overall distribution pattern on the body. Are they primarily located centrally on the trunk or peripherally on the limbs, or is there a specific pattern of spread like palms and soles?
Where it is on the body is key.
Very key.
With all those variables, different lesion types, configurations, and distributions, how do you use this information to approach the diagnostic puzzle of fever with rash? How are these rashes classified systematically?
This section of the material focuses on rashes that are manifestations of systemic diseases, intentionally excluding localized infections like cellulitis or impetigo, although those can certainly cause fever locally.
Right, we're looking at systemic causes.
The fundamental approach is to classify the rashes based on their primary lesion morphology, what the lesion is, and their distribution pattern where it is.
So what the bumps or spots look like and where they are on the body, those are the two main axes.
Precisely. Using this framework is key to narrowing the broad possibilities. So what does this all mean? It means that by systematically examining the rash, identifying the basic lesion type, using that precise vocabulary we just covered,
Macule, papule, vesicle.
and noting its distribution, you can place the rash into a category that significantly limits the list of potential underlying systemic causes.
That helps focus the investigation.
Absolutely. The sources do acknowledge that presentations aren't always perfectly textbook. Rashes can evolve over hours or days, changing their appearance.
They can change.
And classic presentations aren't always seen. A prime example is Rocky Mountain spotted fever, while the classic rash is peripheral petechia starting on wrists and ankles.
The textbook case.
It can start as blanchable macules, might not be prominent on the extremities initially, or sometimes the rash may not appear at all in up to 10–15% of cases, which presents a significant diagnostic challenge.
Wow, no rash in RMSS sometimes. Tricky. That highlights why this systematic approach is essential, but also that you need to be aware of variations and exceptions.
Exactly. Clinical judgment remains crucial.
What are the main categories of rashes with fever discussed in the text, based on morphology and distribution?
The material classifies the diseases presenting with fever and rash into several categories based on their typical pattern of eruption and distribution.
Yeah.
These include centrally distributed maculopapular rashes, mostly on the trunk.
Like measles or rubella might be.
Potentially, yes.
Yeah.
Then peripheral rashes, maculopapular or maculopapulars starting on limbs. Confluent desquamative erythematous rashes, like scarlet fever, looks like sunburn with peeling.
Right.
Vesiculobilous rashes, blisters like chickenpox or herpes. Urticaria-like rashes, scives. Nodular rashes.
Nodules we defined.
Purpuric rashes, both non-palpable petechilosis and palpable purpura. Ulcerated rashes, or rashes that characteristically present with eschars, that black scab.
So you put the rash into one of those buckets based on what it looks like and where it is?
That's the idea. The text lists numerous specific diseases that fall into each of these categories, providing that structured framework for diagnostic consideration.
That makes perfect sense. You identify the category based on your physical exam findings, and that immediately gives you a focused list of the most likely culprits to investigate further with targeted history, physical exam details, and labs.
It provides a crucial organizational tool in the face of a potentially overwhelming array of diagnostic possibilities when someone presents with fever and a rash. A way to cut through the noise.
We have taken a truly deep dive today, covering a vast amount of fundamental material on fever and rash.
We certainly have gone deep into the details, hitting all those key concepts from the sources.
We started by exploring the intricate ballet of temperature regulation, dissecting the role of the hypothalamus, understanding the critical distinction between fever and hyperthermia,
That set point difference.
and tracing the fascinating molecular cascade involving pyrogens, cytokines, PG2, EP3 receptors, and CAMP that precisely resets the body's thermostat upwards.
The whole pathway.
We then moved to the clinical front, discussing how to approach a patient with fever, considering factors like blunted responses, the utility or lack thereof of various lab tests, the significance of fever patterns,
Like the tertian or quartan fevers.
the role of anti-cytokine therapies in both infection risk and autoinflammation, and the mechanisms behind and clinical application of different antipyretic medications.
How acetaminophen differs from NSAID, the role of glucocorticoids.
And we concluded by diving into the world of fever combined with rash, emphasizing the importance of a detailed history specific to the rash.
When did it start? Where? How did it spread?
Learning the precise, expert language to describe various skin lesion types, from macules and papules to vesicles, bullae, purpura, and eschers.
Mastering that vocabulary.
And understanding how classifying these rashes by their morphology and distribution provides an essential diagnostic framework for pinpointing the underlying systemic illness.
Using those categories to narrow it down.
For you, the learner, immersing yourself in these specific details, from the exact temperature thresholds defining fever in modern studies, to the precise molecular signaling pathways in the brain, to the rigorous vocabulary for describing a skin lesion, is how you move towards truly mastering this foundational information about these cardinal signs of illness like an elite professional.
It's about building that deep foundational knowledge.
It equips you with the deep framework needed to interpret symptoms, appreciate the body's complex signaling systems, and approach these common but often challenging clinical presentations with confidence and a comprehensive knowledge base drawn directly from this detailed material.
It provides the essential scientific and clinical grounding needed to accurately understand and evaluate what the body is trying to tell us through these powerful signals.
As a final thought to leave you with, drawing from everything we've covered, consider how the body's incredibly complex thermal control system, which is so finely tuned for maintaining precise homeostasis, possesses the capacity to be fundamentally altered or completely overwhelmed in such dramatically different ways.
It's quite remarkable.
You have the carefully regulated, though elevated, temperature of fever as a defense mechanism, orchestrated by that intricate signaling cascade.
A programmed response.
Or the potentially catastrophic uncontrolled heat of hyperthermia when that control fails or is overwhelmed.
A system breakdown.
What does this duality, this capacity for both highly programmed response and chaotic breakdown within the same system, tell us about the body's strategies for dealing with stress and disease and the ultimate limits of those strategies?
It's a powerful illustration, isn't it? It highlights the body's resilience and its inherent vulnerability, all captured in the story told by temperature alone. Something to really think about.